Hello, and welcome to Cuts, 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 what the federal budget mess means for prevention, your community, and you. If you experience technical difficulties during this WebEx session, please dial 1-866-229-3239 for assistance. The audio portion of the web form can be heard through your computer speakers or a headset plugged into your computer. If at any time you are having technical difficulties regarding audio, please send a question in the Q&A panel, and we will provide the teleconference information to you. We are encouraging you to ask questions throughout today's presentation. To do so, simply click the question mark icon, type your question in, and hit send. We will be addressing questions both throughout and at the end of the presentation. We will be using the polling feature to get your feedback during the event. The first poll is on screen now. Please select your answer from the available choices and click the Submit button. It is my pleasure to introduce the moderator of today's event, Matthew Marsom. As Vice President of Public Health Policy and Advocacy for Public Health Institute, Matthew is responsible for designing and implementing PHI strategy for monitoring and influencing public policy, legislation, and regulations affecting PHI projects and public health policy relevant to PHI interests. Matthew, please go ahead.
Thank you very much, Star, and good afternoon or good morning, everybody. Welcome to this next in our ongoing series of Dialogue for Health web events, Cuts, 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 what the federal budget mess means for prevention, your community, and you. I want to thank all of you for joining us. I know how busy schedules are and how challenging the times are that we live today, as we're looking at the impact of sequestration take effect and deeply impact the work that we're doing in public health, healthcare, and human services across the country. So thank you to everyone for joining us. We do have, I think, a stellar panel assembled to talk about these issues and the impact on public health and prevention. And I'm in a moment going to introduce the panel for you, but I wanted to remind you again about Dialogue for Health. It's a project at Public Health Institute where we mingle the expertise of public health professionals with the perspective of business, government, and other community interests and provide a web-based platform for interaction and discussion. And D4H tackles provocative subjects and builds the foundation of understanding to craft policies, systems, and environments to reduce chronic disease in the United States and globally as well. And we also have a social network that we encourage you to check out. I encourage you to go to our website, phi.org, where you can find more about Dialogue for Health, or go directly to the D4H website, Dialogue for Health, that's the number 4health.org. Today we'll be using, as well as the Q&A features, and so as you're hearing the panelists speak and you want to ask questions, we encourage you to send in your comments and questions with the Q&A feature. So with that, I would like to now introduce our panelists, and a familiar face and voice to Dialogue for Health is Adrienne Hallett, who's on the professional staff of the U.S. Senate Committee on Appropriations, and joins us regularly to talk about the latest shenanigans on Capitol Hill and the impact of all of the political negotiations on public health funding and priorities. And Adrienne serves on the majority staff of the committee, and her responsibilities include annual funding of her programs in the Health Resources and Services Administration, CDC, and the Centers for Medicare and Medicaid Services. So Adrienne, thank you for joining us again. Another prior participant and familiar voice and face to Dialogue for Health is Emily Halubowicz, the Executive Director of the Coalition for Health Funding. And she helps her clients promote and protect their interests in the nation's capital and leads the coalition tremendously. I mean, I can't tell how wonderful it is to know that Emily's there leading the Coalition for Health Funding in Washington, D.C., representing our interests and the diverse group of partners that are members of the coalition. So thank you, Emily, for joining us and sharing your insights today. We're also very grateful for the participation today of Dr. Donald Schell, the Director of the Cancer and Chronic Disease Bureau at the Prevention and Health Promotion Administration for the Maryland Department of Health and Mental Hygiene. Dr. Schell has been invited today to share the successes and the work that they're doing in Maryland with the Community Transformation Grant Program. I encourage you to review his bio, which is extensive. It's also going to be posted on the Dialogue for Health website, where you can read more about the work that he and his team are doing there in Maryland. But Dr. Schell believes that critical healthcare choices, some and out of control of individuals and populations, are impacted by their relationships, education, life experiences, housing, employment, nutrition, etc. And those social determinants that we've discussed before at Dialogue for Health are really critical to the conversations we have using this platform and also the work that we're all doing together through this work. So thank you, Dr. Schell, for joining us. We greatly appreciate your participation. Another strong partner and familiar face on Dialogue for Health is Sue Polis, who's the Director of External Relations and Outreach for Trust for America's Health. Is the outreach new? I didn't know, Sue, that was included in your title. That's great. So wonderful to have you here. And Sue is one of our the key leaders that puts together this series for Dialogue for Health, and along with Sana at Prevention Institute. And we couldn't do it without you, Sue. And we couldn't do it without TIFA as well. They're tremendous leaders and advocates on behalf of public health in Washington, D.C. So thank you, Sue. And last but not least, Sana Shamini, the Program Director at Prevention Institute, and we're all familiar with Prevention Institute's tremendous national leadership on these issues. And Sana oversees projects related to community prevention, health reform, and communications, and is just, again, a tremendous partner in helping to put together this series and provide leadership on prevention issues nationally. So that's our panel, and I want to acknowledge and thank the sponsors, including the American Public Health Association, Prevention Institute, PHI, and Trust for America's Health. And you can read more about them on the slide deck. You can download these slides after today's forum, so I'll just skip over that and just highlight the agenda. So we're going to start out by hearing from Adrienne and then Emily on the impact of federal funding cuts and hear the latest about the sequestration as well as the competing budget proposals that the House and Senate have proposed and what the current status is on Capitol Hill. We're going to hear from our invited speaker about the successes of the CTG program and the prevention fund work that's going on, not just in Maryland, but we'll have an opportunity to hear from you, our audience, as well. We're going to discuss outreach tools and messages that individuals can use to share the successes of their program, but also, for those of you that can and are able to educate legislators and decision makers about the success of this work. And we're going to have an open Q&A discussion as well. And again, remind you to go to the Dialogue for Health social network, dialogueforhealth.ning.com, to find out more. And so with that, let me just check, make sure. Yep, I'm going to bring up poll 2 before we hear from our panels. And poll 2 is on your screen now, so I really encourage you to look on the right-hand side of your screen and answer the question for us. How familiar are you with the details of the current Republican and Democratic budget proposals and their impact on funding for prevention and public health? Again, how familiar are you? Please click your response and click submit. You have like a minute left. And we really encourage you. It's important that we hear from you, and please submit your responses. And with that, I'm now going to hand over to Adrienne, and if you can unmute yourself, we'll hear from you with an update on the latest from the Capitol. Adrienne, over to you.
Well, hello, everybody. I'm going to jump in and talk about the budget. My goal, I'll go to the beginning of my presentation. My goal in talking about the budget is to give you some context. You know, when we talk about budgets here, they are often at the 30,000-foot level, and it's hard to understand what the impact is on a program or a series of programs or a suite of programs that you particularly care about. So my hope is that as a result of this conversation, you are more able to, as you read your newspaper, this conversation is a very public conversation that we're having about the budget, able to put your concerns and the programs and issues that you work on in the context of the budget. So getting started, just a little bit of background. In FY13, I just wanted to give a sense that the part of the budget that we are really talking about is on the top left. It's this brown piece. That's the non-security spending. So you'll often hear people say, don't cut Social Security, don't cut Medicare, don't cut Medicaid, don't raise taxes, or don't cut defense. This little brown piece is where most of the budget conversation has had, and I know Emily after me will have more to say about that. We often hear that the way to get our deficit under control is to cut spending, quote unquote, cut spending. And when that's said, often it's in a context of, no, we don't mean the Pentagon, we mean all the other stuff. So I put this up just to show that in 2013, we will accrue that much additional debt, and this is the total of non-security spending. So when you look at that, the brown piece, it's such a small part of our budget picture that you could eliminate the whole thing. the national parks, the Social Security Administration, the people who actually pay the benefits, the National Institute of Health, biomedical research, the FBI, NASA, you name it. You could eliminate the whole thing and we would still add to the deficit every day. So, deficit reduction to date. We have been working on reducing the deficit for the last 18 months to 2 years. You all might remember there was an awful, awful April week where we threatened to shut down the government over this spending fight in 2011. And we agreed to some cuts in 2011 and 2012. Those cuts lowered the discretionary spending trend by $550 million over 10 years. Then we had a big fight over the debt ceiling. And in that, the Budget Control Act, you'll hear me say this acronym a lot in this presentation, BCA, the Budget Control Act. That is current law on what our budget is going to look like over the next 10 years. The Budget Control Act lowered those discretionary caps over 10 years by $900 billion. Then we did the Taxpayer Relief Act this past December. You know, a lot of people reported that raised taxes, but it didn't cut spending. It's not actually accurate. There was $14 billion worth of discretionary spending cuts additional in that act. In addition, ATRA raised $617 billion in revenues. So the interest savings, foregoing the debt, is about $300 billion. To total that up, deficit reduction to date has been $2.4 trillion before we get to sequestration. $1.7 billion in cuts to discretionary, $700 billion in revenue when the interest foregone is added to that. So we've done about $2 to $2.50 of spending cuts for every dollar raised in revenue to date. That's where we are right now. So let's talk about sequestration. There's been a lot of conversation out there about it. There are some recent actions just in the last week that will really impact how sequestration gets applied to programs that I think are helpful for you all to know about. First, the continuing resolution is about a 5% cut. Now, you probably have read and heard a lot about flexibility and what flexibility the government has over it. This is sort of technical, but because the Labor, Health, and Education bill is in a continuing resolution, that means we write a very short bill that says to the government, hey, administration, continue everything what you did last year. Instead of setting a level for each program, project, and activity, we actually said just continue the accounts the way you did last year. Well, that gives them flexibility because the targets that they have to meet are a 5% cut at the account level. So for example, the Center for Chronic Disease Prevention at the CDC is one big number. They have to cut 5% from the total. They don't have to cut 5% from each individual. I think there are 50 programs within the Chronic Disease Center. They will have flexibility within that account level. In addition, there is a traditional transfer authority in our bill. They can take 1% from any account. They can increase no account by more than 3%. So those are the two types of flexibility that they have as they implement the sequester. There's a requirement in that continuing resolution, which I have my fingers crossed that the Senate is going to finish tomorrow, maybe. I had hoped for yesterday, but, you know, we'll take tomorrow. There's a requirement that they submit operating plans 30 days after enactment. So it's our hope that, since sequestration has already been enacted, that those operating plans in 30 days will give you all a sense and give us a sense of what they intend to spend on each individual program in the government. So keep an eye out for those. I expect the bill to pass in the next week or so, so figure about 40 days from today. On the Prevention Fund. So the Prevention Fund is a mandatory program. Because of that, their sequestration cut is a little bit different than the discretionary programs. Their sequestration cut is about 7.8%. So that, for the Prevention Fund, the math is easy. It's $1 billion, so it's a $78 million cut. The Prevention Fund, again, is one big number. So that $78 million cut can come from anywhere within that $1 billion. just to give you a sense of how the prevention fund is being used right now, about half the fund goes to 3 major activities: the community transformation grants, Section 317 immunization programs, and tobacco prevention and control. It's actually a little bit more than half, but it's close. About a quarter of the fund goes to core state health operations, things like epidemiology, screening campaigns like viral hepatitis, surveillance, the National Center for Health Statistics, those sorts of activities. The remaining quarter is a lot of smaller initiatives, support for the prevention research centers, primary and behavioral health integration, Alzheimer's programs, a big wide variety in the last quarter. So I don't know. I have heard nothing about what the administration plans to do with the prevention fund, but I am hearing rumors that we will find out sooner rather than later, possibly in the next few weeks. But I expect definitely by the time we get those operating plans that we will have a sense of where the prevention fund is going to be used in FY13. Is the sequestration here to stay? So sequestration, cut $1.2 trillion over 10 years. So sequestration, a lot of people think it's just a this year issue. It's not. Sequestration is actually in current law going to hit each and every year. The Senate budget resolution and the House budget resolution are a little bit different. The Senate budget resolution creates a path with fast track for legislation, with lower voting thresholds. It prohibits filibustering. Any plan to replace sequestration with a mix of spending reforms and revenue provisions. So the Senate budget resolution really puts us on a path to trying to get rid of sequestration for all 10 years. The House budget resolution approaches sequestration by implementing it within discretionary caps over the whole 10 years, but with one difference. It moves all of the defense cuts to the non-defense budget. So just to give you a sense of what that looks like, this is a busy chart, but will take just a minute. And in part, I didn't want to get too detailed on the numbers because I've spent the last 3 days reading both budget resolutions, and it's complicated for me. So please forgive any fuzziness, particularly in the out years. I think I'm pretty good on the first few years, but it gets a little fuzzy toward the end. The first 2 bars, the purple and the green, are what's in law right now. The purple is what is in law with BCA pre-sequestration. This is all the non-defense spending. And I want to pause for just a second here to tell you why I'm so focused on non-defense. First of all, it's the only thing you can tell. At this level, they don't drill down to the CDC level or the NIH level. Non-defense is what we know. To give you all a good guide, when you read about or hear about non-defense spending, the bill that funds public health, the labor, job training, healthcare, education bill, is about half of non-security spending. So it's about a third of non-defense. Difference between defense and security is that Homeland Security and VA are included when we talk about security. So in these non-defense numbers, when I tell you that there's an X% cut or a X dollar cut, about a third of that is what this bill, the Health and Education bill, will be trying to come up with. So Budget Control Act, this is pre-sequestration, post-sequestration, and then the pink lines are the 2 competing budgets that are on the House and Senate floors. We're hoping to get to the Senate floor in a day or 2. The lower one, the hot pink one, is the House budget. The lighter pink is the Senate budget. So you can see the Senate budget really tried to maintain and put back the money from sequestration. In the outer years, I think they tried to slow the growth a little bit, but at least not cut. You can see that the difference between sequestration, the post-sequestration, and the House budget is that shifting of sequestration from defense to non-defense. So those are really deep cuts that you would see on our side. There's also another little detail about the budget that you wouldn't necessarily look at. In current law, we allow $12 billion a year to go to emergency fund in case of a natural disaster, in case of a Katrina or a Rita or a Sandy. In the House budget, they eliminate that fund. In the next 10 years, any emergency would have to be paid for out of non-defense funds. So in addition to these cuts that you see in the hot pink line, any additional cuts would have to come, any additional emergency spending would lower that hot pink line an additional however much is needed. So that's a detail that's really important. Now I'm going to take a look at 2014. Just do a little bit of a close-up on the graph we just saw. This is 2014 before sequester, 2014 with sequester. You can see that defense number at the bottom kind of shifting around in different proposals. The pre-sequester and the Senate budget is very similar. The Senate budget also has a $50 billion fund on infrastructure, so trying to do a little more stimulus package. And some of us like to see the numbers. I was doing all these charts and I thought, well, gosh, you know, I looked at those charts and me as a numbers person, it would drive me crazy to be out there watching my presentation and not be able to pinpoint exactly what we're talking about. So this is compared to FY13, the bill that we're working on finishing right now. Non-defense is $491 billion. Pre-sequester for FY14 is a little bit of an increase. Post-sequester, a decrease. House budget, even more of a decrease. Senate taking us back to that 2014 BCA pre-sequester level. So some of you probably out there wrote those down and did the math real quick. The House budget for non-security spending is a 16% cut from FY13. It's $77 billion. That, you can also think of that as an 11% cut below the 14 level after the sequester is already subtracted. It's a $22 billion cut on top of the $55 billion cut on top of a $22 billion cut. Now, so far, I've been pummeling you all with really big numbers without much of a sense of what that means. So just to put things in comparison, CDC's budget, the discretionary money, is $5.6 billion. The total for the prevention fund is $1 billion. The entire cost of operating Medicare and Medicaid for a year is $3.8 billion. So when we talk about cutting $77 billion in 1 year out of non-security spending, and remember, I told you that about half of non-security spending is this job training, healthcare, education sector. You're talking about $36 billion in a budget where it would require, you could think of it as eliminating CDC 5 times over. You'd almost get there. The entire budget of the NIH is about $37 billion. So this cut in non-security spending, if we take our share, would mean eliminating, the equivalent of eliminating NIH. Now, I'm not saying that that's what people would choose to do, obviously, but there aren't a lot of places to go. You know, over the last 2 years, we've eliminated 66 programs in the labor age bill. Very important programs that people care about very much. So there aren't places in the labor age bill that people don't care about anymore. If we have to face this level of cuts, there will be drastic differences in the kind of services that we can provide. So, timeline for you all to weigh in on this. March 27th, we have to finish FY13, or the government shuts down. I don't think there's a chance that the government's going to shut down. I'm hopeful that we'll actually get it finished later this week, so that's completely off the table. In mid-April, that's when those operating plans will come forward, and you will have a chance to weigh in on what you think about the final decisions. April 15th is the deadline for these 2 competing budgets to be passed in both the House and the Senate. We actually expect the House to finish work this week. We were hopeful that the Senate would finish work this week. We're waiting to see, Mr. Moran of Kansas is holding up the FY13 CR right now, so we are waiting to see how they will proceed on that. In April and May, you should expect to see hearings on the HHS budget. So people will be submitting a lot of questions for the secretaries about how they are implementing sequester, and we would, love to hear from you all on that. And we've set a deadline. Many of you have asked us to set a deadline for when we expect to hear your input on the President's budget, and we've set May 10th for that deadline. And finally, I have to say, listening to my budget presentations is often depressing for people. So I'm giving you what I like to do when I get depressed about the budget is go to puppies.com. So thank you for listening to me, and I'll be happy to take any questions about the budget.
Thank you, Adrienne, and thank you for bringing those puppies with you. It makes the whole world seem like a better place after listening to that presentation. Thank you. No, I mean, I really appreciate the insight you've provided to us, and I'm going to move quickly to Emily so that we can take both of you together before we take specific questions. But I will remind the audience that we would encourage you to send in comments, questions to the entire panel. If you listen to Adrienne and you have questions you want to know about, well, what does this mean for your state or your community, we want to hear from you as well. So please send in those comments now. And then with that, I'll hand over, if we could switch the slides to Emily, and we'll hand over to Emily Lubowicz. Emily, over to you.
Great. Thank you so much, Matthew, and thank you, Adrienne, for that great presentation. I follow this a lot. I'm often confused, and I learn something new every time I get a chance to speak with you, so thanks so much. I'm going to sort of try to synthesize what Adrienne just reviewed for you and what that means, I think, for the broader advocacy context. As Matthew mentioned, I lead a group called the Coalition for Health Funding, which is now about 84 national health organizations that are advocating for the public health continuum. So this idea that really all agencies of the public health service are important to improving health. And keeping everyone together can be a challenge at times because we do have, in general, finite resources. And what we then see sometimes is that in order to get an increase at one agency or for one program, it needs to come from somewhere else. And so really the motto of the Coalition for Health Funding is all for one and one for all, and we try to really make sure that we don't end up cannibalizing each other at the expense of each other and at the expense of health. I think what concerns me and what concerns I think many of us in the community is that we are entering an era of austerity that I don't think we've yet seen, and I don't think people yet fully realize just how difficult it's going to be to sustain current levels of funding, let alone try to achieve increases. And so what this does is breed an environment that I've now started calling Lord of the Flies, where it really becomes every man for himself, which, as someone who runs a broad-based coalition, makes me very nervous. And so we're thinking through ways to try to make sure we stay strong and we stay together, because I think we're stronger united than divided. So what I'll do a little bit is show you more charts that are sort of the broader picture over time and talk about what that may mean for advocacy and for advocates and for public health, and then what you can do about it. I always like to begin with this because I feel like, and I've been using this slide for many years, and just when you think it can get worse, it does, it seems, so I should maybe take it out. But I feel that for folks who have worked in this area for a very long time, the process has never really felt more broken. It can often feel as though there's no hope. I think there is still some hope that we will turn this around. Unfortunately, in many respects, I feel like as a society we are in a place where we really don't know what we've got till it's gone, and almost in order for people to appreciate the role of government in their daily lives, they need to live without it for a little while. And so I think part of our fear is, for example, sequestration, I think, will be undone. The pendulum always swings. This is not the first time in history we've faced sequestration, and it swings back. And so you could say maybe this is a phase, but there'll be a lot of damage that happens in the meantime. And it may take longer for us to realize what we've done than in some of the other instances, just because of the very nature of sequestration and the budget cuts that we're talking about, which by design are drawn out over time so you don't feel too much all at once. And so this is just a different presentation of what Adrienne had. I'd love to steal everything from the Center on Budget and Policy Priorities here in Washington, D.C. I think this shows the picture sort of before the real cutting began. We've really been cutting since fiscal year 2010, as Adrienne pointed out, and obviously if you take into account the loss of Recovery Act funding or the stimulus funding, that is not depicted here. We don't include that in any of these totals as sort of a bolus funding. But this is what the budget looks like, and I think it's important because there are a lot of misperceptions among the general public about where we spend our money. And then within health, in that little red sliver, health discretionary, which many of you on this call care about, namely NIH, CDC, FDA, HRSA, all that represents only about 1.7% of what we're spending, and this was in fiscal year 2011. And of this, about 1% is NIH. So that 0.7% is everything else. So it's actually a very, very, very small portion of what we're spending. Obviously, all the other non-defense discretionary spending and really discretionary, the area of the budget where Adrienne talked about we've been concentrating cuts, is really in an area of the budget that, frankly, is not driving the deficit and the debt and is having a negligible impact on the debt, which for advocates for public health funding is very frustrating because it often feels as though we're cutting for cutting's sake. And I have some charts, of course, to help back that point up. So here's, I think, a helpful chart about, so why do we care about deficit reduction? Because I think it is important to note that the deficit and the debt is a problem. And this is from the Bipartisan Policy Center showing a projection over time that essentially our debt will reach 100% of our GDP in the year 2027. And so that's really what's driving this obsession with the deficit and the debt, is that in our lifetime, our GDP to debt ratio will be 100%. It's now about 70%, 72%. There are lots of different reasons why we have growing deficits. We have historically low rates of revenue. Historically, tax rates are at a low. As a percentage of our GDP or our economy, the revenue we're bringing in on average is about 18%. Historically, it's been around 20, 22%, but it's not just because of tax rates, and that's where a lot of the debate and the discussion on TV and the Sunday morning talk shows tends to focus, but it's also what you would expect during a recession. You have fewer people working, therefore you have less people paying taxes, less revenue coming into the federal government, and historically in times of recession and depression, you see this precipitous drop in revenue. So we have low levels of revenue coming in, and we have higher spending. And the areas where we see higher spending, or you hear the soundbite, spending is the problem on TV, are not the areas of the budget that we've been cutting, as Adrienne pointed out. It's really, and it's true on the discretionary side as well, what's driving federal spending is currently and into the future is escalating healthcare costs. And it's not just the entitlements, but it's also healthcare in the military, it's veterans healthcare, which are technically considered discretionary. So I think healthcare spending, economists widely recognize as one of the drivers of our deficits and our debt. And to drive home this point, you know, I think important to note that a deficit simply being the difference between the money the government's bringing in on an annual basis and the money the government is spending. If you don't have enough to pay for what you want and you end up borrowing, that continued borrowing over time to make up for deficits is what contributes to our debt. What we're seeing is a situation in which you could eliminate discretionary spending. So that includes the Department of Defense, CDC, Department of Education, get rid of all of it. And we are still running deficits of about $500 billion a year. And so as advocates for discretionary funding, for particularly in public health, that's a point we really like to emphasize, is that the areas of the budget that you've been cutting over time are not what is driving the problem and is having a negligible impact on the solution over time. Adrienne talked a lot about the Budget Control Act, and so pre-sequestration, I like to call it, before sequestration even took effect, this is what the pie looks like under the Budget Control Act and the discretionary spending caps that have been established to contain discretionary spending. This is what the pie chart then looks like. Again, based on projections of increased spending in terms of entitlements. You'll notice the gray area of this pie chart. In fiscal year 2011, our interest on the debt, that is the interest that we pay on the funding that we borrow when we're running deficits, increases from 6% to 15%. That's considered mandatory spending. That means our debt is continuing to grow even under these discretionary cuts. And non-defense discretionary spending shrinks from about 18% of all spending in fiscal year 2011 down to 11%. What's not shown on this chart and in that orange slice is increasing demand on programs within this non-defense discretionary category. For example, veterans health care. And the Center for Budget and Policy Priorities did an analysis earlier this year looking at this effect, and that over the next 10 years, under the Budget Control Act caps, again, this is before sequestration, if we are to provide the same level of services that we are providing now in fiscal year 2012, we are going to need $600 billion more than what's available under the discretionary spending caps. And so what you see is not only a shrinking piece of the pie for non-defense discretionary programs, but within that piece of the pie, you've got elements of non-defense discretionary that are going to be increasing and crowding out what's available for everyone else. And again, this is an effect that I don't think people fully realize, but will have a significant impact on our ability to sustain funding for public health programs. And it also, again, then breeds this environment where we need to rob Peter to pay Paul, and where we have to date really worked hard to try to unite the non-defense discretionary community to try to protect this piece of the pie. You could see in an environment where funding is seriously constrained, people start to become desperate, and we start trying to fight amongst ourselves to get whatever scraps we can left from the budget table. I think this line chart from the Bipartisan Policy Center is particularly compelling because it shows, I think, the different levels of cuts and where we are historically. So it's showing that historically, as a percentage of our GDP, non-defense discretionary spending for programs like public health and research and education has been about 3.9-ish to 4%. The trend lines then that you see is the green is sort of the trend we were on for non-defense discretionary spending before the Budget Control Act. The blue line you see is where we are under the Budget Control Act caps. So that's the law that Adrienne described in detail, again, defining and limiting the size of the overall pie for discretionary spending over the next decade. And that red line is then what happens with the caps and under sequestration. And I would love, and maybe I'll ask them to update this, but to just for comparison to show where we are under the proposed Ryan budget in the House, which is dramatically worse for NDD than even BCA plus full sequester, that red line. But then what it shows is if you look at that purple dotted line, horizontal line, that's where non-defense discretionary spending was at our lowest point. So the historical average as a percentage of GDP was about 3.2%. That's as low as we had gone. Under the even just the Budget Control Act caps, let alone sequestration, we are shrinking non-defense discretionary to levels not seen really since Eisenhower was president, which is the earliest that the Bipartisan Policy Center and CBPP have had data on tracking NDD as a percentage of GDP. So when you hear people talking about spending is the problem, it's not these programs for a number of reasons. And why this chart, I think, is compelling is it shows that, remember that initial red line that showed by 2027 our debt to GDP ratio reaches 100%. Under sequestration, we only delay that by 2 years. So the impact that these cuts are having on the actual problem is negligible. Yet the impact they're having on our capacity to day-to-day provide core and essential public health and preventive services is seriously compromised. And as Adrienne noted, unfortunately, we don't really know the extent to which, particularly in the out years, it will be compromised, but we know it's coming, and we're bracing for the worst. Adrienne covered most of this, and I think the point to take away is that there's a lot of uncertainty around sequestration, and particularly it makes it a challenge to communicate the impact. You may have noticed for about 10 days before sequestration was to take effect on March 1st, the President was out there, and he had his soldiers out there, the secretaries of his department, talking about the impact of sequestration, how devastating it would be, how horrible it would be, and then March 2nd came and nothing happened. And as we feared, I think the reaction has been, oh, see, sequestration's not a big deal. Oh, you know, we've only cut 1% of everything we spend every year. Who can't cut 1%? What's the big deal? Of course, they're using the wrong denominator when they say those things, but nonetheless. So what we're facing now is an environment where, to some extent, and even for advocates who've been talking for a long time and trying to communicate the impact, where it's the boy that cried wolf. You told us all these things were going to happen, and nothing happened. So what's the deal? And so what we're trying to do now is educate policymakers about how sequestration works, because there's a lot of confusion about and misunderstanding about how it works. We're trying to talk about how we expect it might work and when. Sequestration is not like a government shutdown. It is not like the lights are off and buildings are closed and national park gates closed. There's a series of decisions that have to make at the administration level and then down on through the line of people who receive federal funding. And that takes time. And we're currently awaiting more detailed instructions from OMB and from the department and from the agencies about how they are going to apply sequestration's cuts. And until we know that, it's really hard to talk about impact. We are starting to see now, and I think the reporting at the local level has been much better on this, the media coverage. We're starting to see now, particularly among the defense contractors and the defense industry, furloughs and layoffs. So that's sort of, I think, the first wave. And actually, layoffs have been happening in the defense sector now for several months leading up to what they expected would happen, which is, of course, sequestration taking effect. What we could see is, again, because at each level of decision-making there's a certain amount of flexibility, your grant might not be cut at all, or For example, you might see, if you're a federal agency that is like the FDA, where you don't have really an extramural budget. You're not doing grant making. You're not doing a lot of contracts. It's very staff heavy. That to get the cuts that FDA has to contribute to sequestration, they're going to have to probably furlough staff. Unlikely that they'll do a reduction in force, but there's very little flexibility for them in terms of, okay, where are we going to get the money to come up with cuts, because they're very staff-heavy agency. For an agency like CDC that has 75% of its budget going out the door, well, now you have a decision. Do you furlough your staff, or do you make extramural programs bear the brunt of responsibility for sequestration? In which case, the cuts may not be 5%, they may be more like 10 or 12%, again, depending on the intramural versus extramural mix, and also within the extramural, is it existing grants? Are you holding contracts harmless? Do you keep contracts in the mix? Are you sustaining funding for existing grants and contracts and just not offering any new? There's a lot of different ways that you can cut this, and unfortunately at this time we just don't know what sequestration is going to mean for 2013, and we certainly don't know what it's going to mean for 2014 and beyond. I think there are hopes that, and the President has been doing a lot of courting of moderate Republicans to get them on board with a bold, big, balanced deficit reduction package that has entitlement reform, has more tax reform. That's a heavy lift. I think they're looking at the debt ceiling and coming up on that in July, which is, interestingly, how we got into this whole big mess to begin with 2 years ago with the Budget Control Act. But trying to use that as a way to force compromise, to undo sequestration, and to have a deficit reduction package that's going to get us to that $4 trillion target. We've already done about half, and that's going to actually address the true drivers of the deficit and debt, namely entitlements and taxes. Now that's a heavy lift, but it's something that we're optimistic about and we're hopeful about. And so what can you do? I think at this point our message is do anything. There is no wrong way to engage at this point. I think the typical modes of communication, calling, writing, visiting elected officials either at home or if you're here in Washington, D.C., are effective. We've seen more use of social media in terms of trying to connect with policymakers and reporters to talk about sequestration and the impact of continued cuts through Twitter, through Facebook. Several groups are doing video testimonials, posting them on YouTube and then tweeting them or posting them on members' Facebook pages and Twitter accounts. Members are often at home for town hall meetings. That's a good place to try to get some face time, try to engage them in issues about debt reduction, deficit reduction, and also talk about the impact of sequestration, keep that on their radar. And of course, using local media. Again, local media has been doing a great job of covering the impact of sequestration. They're starved for stories on this. So as you know what impact this is going to have, reaching out to that local media, print, TV, radio is all great. I think in general our message is stop sequestration, stop cutting for cutting's sake, stop cutting non-defense discretionary. We've done our part in the public health space, and start working on a bipartisan, meaningful deficit reduction strategy that will actually address our debt in the long term. And most importantly, and I think doing this proactively, we have to tell the story. And I know in public health we love data and we love being in the aggregate, but the most powerful, impactful data, if you will, is that N of 1. It's what are you experiencing on the ground right now, either yourself and your family, because it won't just be in your public health space, but what are you feeling, what are those you serve feeling, and documenting and sharing those stories is going to be absolutely critical, and doing it as they happen, not just retroactively, because we're going to need those to make the case, and it's the only way we're going to turn sequestration around. In this, I'd just love to show Senator Harkin had a great rally on Capitol Hill last summer, which we had the pleasure of helping them with in terms of organizing, and this is just one of our photos about how these cuts have consequences for lots of different areas of the budget that we all say we care about until we start cutting. So I'm happy to take questions at the end of today's session.
Thank you, Emily. And what I'd like to do is actually, at that moment, bring up poll number 3, if we can, on the Dialogue for Health staff to bring that up, because I do think it's important that we capture right now, as people are listening to you and listen to Adrienne, we need people to take action in their communities. And so as efforts continue to defend the Prevention and Public Health Fund from cuts or elimination, we'd like to know whether you're willing to take action. So please respond on your screen at the moment, and I know we have almost 320 people on the line today. Tell us, are you willing to call your senator, your representative? Are you willing to write an op-ed or a letter to the editor, send an email to lawmakers, participate in a meeting with your legislator or their staff? And of course, if you're not, then let us know too, because, and then please respond in the Q&A if you feel like you wish to, but you've got concerns, you've got questions, you don't know what you can do or not. We have resources, whether it be at PHI, Prevention Institute, Trust for America's Health, the American Public Health Association, and of course others as well have resources for you, and we'll talk more about that in a moment. So please respond to the poll at this moment, and it's multiple, so you can reply on all. In fact, I'm doing it myself right now, A, B, C, and D. I'm willing to take all that action. So please click submit, and while I'm doing that, I'm going to actually go back to one of Emily's last slides, just because we had a lot of grim news, but I like that picture you had, because A, that was a wonderful rally, but B, there is blue sky over the Capitol, and it was last summer, and I know it's still probably pretty cold in D.C., or it was in the last week or so, and it's just a reminder that, you know, if we take action and if we can lift up our stories, there are sunny days ahead for our country, and I do encourage all of us to take action. So we're actually going to go to our next speaker, and I'm going to take a slight different, we're going to change course slightly, but we're still focusing obviously on these critical issues. But I'm now going to move to our invited speaker, who we're greatly appreciative for joining us today to talk about, again, a slightly different tack, but invited to talk about the work that they're doing in their community with these important dollars. And I'm pleased that Dr. Donald Schell, who's the Director of the Cancer and Chronic Disease Bureau at the Prevention and Health Promotion Administration in the Maryland Department of Health and Mental Hygiene, can join us and talk about the important work of the Community Transformation Grant Programs doing in that state. So Dr. Schell, if you are willing to move, I'll click to your slides, or you can click on your name above and move to your slides, and you can move ahead. Thank you, Dr. Schell.
Okay, thank you very much, and thank you for having Maryland participate today, and I'm going to scroll through the slides. You need to
just, perhaps Star can do it for you. Just click to you'll see your name above on the top of the screen. You'll see it says Shell. You just click on that and it will take you right to your slides. There we go.
Thank you very much. Okay, I appreciate that. So with all of the great news that we've heard already during this webinar, a thought came to mind. I found a quote from Arthur Ashe. Arthur Ashe was the first African-American winner of a major men's single championship. He lived from 1943 to 1993. And the quote came to mind, and Arthur Ashe's quote is, "Start where you are, use what you have, do what you can." And so with these times of austere, fiscal restraints and thoughts of losing what we have, I just wanted to just say, I think just to keep it in perspective from a public health perspective, start where you are, use what you have, and do what you can. I'll digress from the beginning of my presentation. When I was in college, I learned in medical school, actually, to finally manage a budget. And I didn't have a checking account in undergrad. I lived at home for undergrad. And when I went to medical school, my parents gave me some money, and I ended up running out of money in my checking account. And I wasn't really good at budgeting when I first got a checking account. And I had $5 left in my pocket, and I bought a loaf of bread and a jar of peanut butter and a motorcycle magazine. And it took my mother a week to mail me a check. This is back in the 80s, in the last century. But I learned to live off that $5 for the course of a week. And I got very familiar with peanut butter and bread, and loaf of bread went a long way. And I brought a magazine to read while I was just sitting in my room with no money. But I learned that, and sometimes in back then as it is today, we may not have a lot of resources, but even with those minimal resources, there's a significant amount of what we can do. The slide that's before you now says chronic diseases are preventable, and many of you have probably seen this slide before, but I love it. It's, preventing tobacco, preventing the consumption of these foods that are very unhealthy, and then telling the individual that you see walking their dog while they're driving, please don't do that because that has no benefit for you and you're burning gas. But eliminating these 3 risk factors would prevent 80% of heart disease and stroke, 80% of type 2 diabetes, and 40% of cancers if we did these 3 things. Now, the Community Transformation Grant, just an overview. The Community Transformation Grant is about $103 million, which was awarded to a combination of 61 states and communities throughout the United States to serve about 120 million Americans. So it's 36 states, 7 tribes, and 1 territory that are funded. And Maryland was fortunately one of those that had a rest of state grant opportunity. That $1.9 million that Maryland received was annual for 5 years. We're now in our 2nd year. And in Maryland, that 1.9 million residents, including about 300,000 rural individuals. And Maryland is an implementation grant and not a planning grant. Now, as we look at the national goals for the Community Transformation Grant, it's tobacco-free living, active living and healthy eating, and clinical and community preventive services to improve hypertension control and cholesterol. So if we do this, and if we're effective, we're hoping in the state of Maryland, as are many CTG-funded institutions across the country, that we'll actually be able to take this small amount of funds for a statewide initiative to reduce death and disability associated with tobacco, obesity, and death and disability due to heart disease and stroke. So you may say, well, Dr. Shell, if you only have $1.9 million and you have a population that totals about 4 million, and in Maryland we have 24 jurisdictions, those jurisdictions that are in blue are the ones that are included in our rest of state application, meaning that the big 5 jurisdictions in the state of Maryland, Baltimore City, Baltimore County, Montgomery, Prince George's, and Arundel counties, those that are colored in gray are actually not included, and those are actually the most populated jurisdictions in the state. But so in looking at this funding that we have specifically for the state of Maryland, we have a few different initiatives, I think, which have helped us to have some early successes. In Maryland, we have something called Healthiest Maryland Businesses, where we say the healthiest choice is easy, a statewide movement to create a culture of wellness, an environment that makes the healthiest choice the easiest choice. And many times in public health and in clinical care, we really think that if we're going to change environments, if we're going to address systems and we're going to address policies that allow people to make the healthier decision become the easier decision, then this must be done in businesses, in communities, and in schools. Now, let's look at tobacco-free living. So for the state of Maryland, we profess by 2016 we're going to increase the number of people with access to tobacco-free and or smoke-free environments. Our focus with the Community Transformation Grant is on low-income affordable multi-housing, parks and recreation, college campuses. We also profess that we're working towards reducing the prevalence of cigar smoking in our high school youth. In the state of Maryland, as I believe it is around the country, more than 97% of adults begin their nicotine addiction at the age of 24 years and younger. And it may vary from state to state. And in the state of Maryland, about 67 to 68% of adults with a nicotine addiction begin that addiction at the age of 18 or below. And so we want to attack these areas specifically. So we have, for example, in Maryland, the Cigar Trap campaign, which some of you may or may not be familiar with. We had some focus groups in Maryland, and the children and the young adults told us during those focus groups some years ago that you could actually buy you could buy a cigar singly from an ice cream truck. And so this ice cream truck has 2 skull cherries on the side of it with children chasing it and a kind of an ominous individual stepping off. But this is a social marketing campaign that we led across the state of Maryland. In addition to that, we've had some early wins. This is a Section 8 housing unit out on the eastern shore near the ocean, near the Atlantic Ocean here in Maryland on the eastern shore. And we have members of this Section 8 smoke-free multi-housing unit that have changed their common areas to smoke-free. We'd like the entire building to be smoke-free where they're living, but for us, this is a significant change for a community to come together and recognize, based on the work with the Department of Health and Mental Hygiene, based on the work with the University of Maryland Legal Resource Center, that's one of our partners, that they have made the change to reduce smoking in their common areas in this multi-unit housing as a result of our Community Transformation Grant activities. Here in the state of Maryland, this is M&T Bank Stadium, the home of the Ravens, and both Camden Yards, the home of the Baltimore Orioles, and M&T Bank Stadium, the home of the Baltimore Ravens, have both gone to smoke-free. We can't exactly take credit for that happening. We think the stadium authority decided on their own, but we think that changing social norms, the advertising campaigns, the discussions that we're having across the state are helping to change the thoughts and minds of decision makers that they should create environments that are smoke-free. And there are hundreds of thousands of people that attend these games on the course of a year. Let's change to active living. So we profess in the state of Maryland to increase the number of people with access to physical activity opportunities. Our populations are those in child care, children in schools, and in worksite locations. So this is an example, and these pictures I'm showing today come from our Photo Voice. Photo Voice, our partners at the Institute of Healthiest Maryland here at the University of Maryland, Baltimore professional schools have a Photo Voice project, and they've been collecting pictures to tell the story about the Community Transformation Grant across the state of Maryland. And this is actually a picture of a playground, but if you look at the playground, that's a swing foundation, but it actually has no swings. And so if we're going to promote physical activity in these communities across the state, so that when we talk about safe places to play and activities for children, we have to look at a very specific community level, are there resources? Is the infrastructure in place for children to actually play? Next slide, safe places for physical activity. In some parts of the state of Maryland, like many places across the country, there are no sidewalks. And if you want individuals to go out and walk from an environmental planning and a structure perspective, is there a need to have conversations to create safe routes for school, safe routes for physical activity, walking and running, or do we want our residents walking on roads with cars at the same time? This is a work site setting where there's a promotion for walking at lunch. And so one of the businesses in our partnerships across the state of Maryland participating in the Community Transformation Grant sent this picture in, that they're having a walking sessions during the day at work. So whether it's school, whether it's work, or whether it's community, our Community Transformation Grant is sponsoring conversations across the state of Maryland to look for opportunities to do what you can with what you have, where you are to get started. So healthy eating. By September 2016, Maryland professes to increase the number of people with access to environments with healthy food or beverage options in child care settings, school settings, work sites, state agencies and facilities, and also in retail facilities. Now, in order to do this, Maryland is participating in activities, as we said, at the community level, and we look at are healthy foods available. So the partner from one of our community partners sent this picture in, and this slide, this particular establishment is located in close proximity to a middle school and a high school. And so if you look at the sign, it says these burgers are available on Tuesday for 49 cents at what particular time? This is from 4 p.m. to close. Is it a coincidence that these burgers are on sale at the time when children are leaving school? Why weren't the burgers put on sale at 8 o'clock in the morning or 9 o'clock in the morning? But so these are the kind of things we're trying to promote awareness of as we educate parents and our leaders in those systems we mentioned to help kids make the decisions. And maybe in your local jurisdiction, you could talk about the availability of food. Should foods be sold, should burgers be sold at such a cheap price, knowing that children in our lower socioeconomic communities are price sensitive? Is this a good idea to offer a burger for 49 cents during the time frame when children are getting out of school, especially if it's in close proximity? This is a picture of an advertisement of a store. This picture is up for 3 different reasons. Maryland, we have a Healthy Stores project in partnership with Dr. Joel Gittelston from Johns Hopkins University. And it's a project that is working to increase the availability of healthy food options on the shelves of stores. So if we in public health and in preventive health tell a store, you should sell skim milk and not whole milk, But if that person who owns that store purchases skim milk and puts that skim milk on the shelf and no one purchases the skim milk, then that store owner is probably not going to purchase skim milk again. Well, the Healthy Stores Project, which began in Baltimore City and has moved throughout some of the rural areas in the state of Maryland, is showing store owners, the little corner stores and country stores, that you can still meet your bottom line and make a profit by stocking healthier food items on the shelf. The two other reasons why this slide is here, because you notice on the right side is advertising the price for tobacco products. On the left side, it's advertising candy. And so for these particular issues, our Healthy Stores Project includes healthy food items, but also looking at how each jurisdiction should address the marketing of tobacco products, signage for tobacco products, placement of tobacco products, and then, of course, having promotions for healthy foods, not only promotions for candy. Because we don't think you should have a sign for candy and tobacco together hanging on the window at the same time. So if we look at our clinical and community preventative services, we profess by the same time period to increase the number of people covered by systems or opportunities that support the control of high blood pressure and high cholesterol. We're working with pharmacists, using health information technology, working in work sites, and addressing state reimbursement mechanisms for comprehensive medication therapy management services provided by pharmacists, and I'll come back to that in a moment. This is a slide of an actual pharmacist that was trained by the School of Pharmacy, one of the professional schools here in the city of Baltimore, as part of our Institute for Healthiest Maryland at the University of Maryland Professional Schools. The work under the direction of the School of Pharmacy has worked to help train pharmacists in different parts of the state of Maryland, and we're training now in other locations across the state of Maryland, on how can the pharmacist's role be expanded in the care of patients so that patients better understand the side effects associated with their medications, how to be more compliant with their medications, to address issues both with their physician and with the patient to ensure the correct utilization of medications. And it's using the pharmacist as a member of the clinical team. Here in Maryland, our Community Transformation Grant work, together with our Healthiest Maryland business work, is working to promote the increased training of more pharmacists who can work alongside with physicians, work inside of hospitals, and actually give that direct expertise, as most of our pharmacists now are being trained as PharmDs, and so with their doctorates of pharmacies, pharmacists are well able and very capable of providing very astute additions to the care of patients, both for what medications to use, which medications to avoid, which complications should not be used for patients. The other part of this, and in the previous slide I mentioned, and I'll go back for 1 second, in this bottom bullet on this slide, we're looking at reimbursement mechanisms. So when a pharmacist is used in this expanded realm, that the pharmacist can be reimbursed for that care. So we know that the literature supports that using a pharmacist as part of the clinical team does improve health outcomes. But the problems currently are that there's no mechanism for pharmacists that are working in the community outside of one reimbursement from CMS for Medicare for medication review, one per year. But there's no ongoing mechanism for a pharmacist in a community setting. So here in Maryland, we're working with the School of Pharmacy, both for our state employees, adding a pilot program for medication therapy management and comprehensive medication therapy management with those with chronic diseases and multiple medications. We're also working with a Medicaid MCO for a pilot project here in the state of Maryland, and how we can show both a large employer like the state of Maryland and a Medicaid managed care organization how incorporating pharmacists into the clinical team can improve outcomes but also save money. Here is a meeting together for the Healthiest Maryland businesses where we engage employers, and we enjoyed bringing together a number of our partners and looking at how, with those discussions, we can have these cross-cutting initiatives, but really bring together businesses from many different sectors. And in each of our environments we go to, we talk about healthy eating, physical activity, we talk about smoke-free environments, and we talk about value-based benefit design. So some of the synergies we have in our Community Transformation Grant. Maryland was fortunately the recipient of a recent State Innovation Modeling Grant from CMS. We're looking at synergies between our community transformation work, also with our state health improvement process, which is a dashboard that's used across the state for looking at data that's available on about 39 different health outcome measures in the state of Maryland. We have many other agencies that we partner with. In the state of Maryland, we work with the Department of Agriculture, Maryland State Department of Education, Maryland State Department of Housing and Community Development. We work with the Maryland State Department of Planning, the Department of Natural Resources, and the Department of Transportation. Without the partnership with all of these different agencies, we would not be able to effectively do what we can where we are with what we have. Because from a realistic perspective, the Community Transformation Grant gave Maryland $1 per capita. And there's a lot of things that we're trying to accomplish with $1 per person. And so with that $1 per person and working with their state agency partners, we work very closely with our Office of Minority Health and Health Disparities, which has a track record of working with a group called Minority Outreach and Technical Assistance that are our minority groups across the state of Maryland that have already worked in their communities to help reduce cancer mortality rates. And we work with them and fund them to do work in the communities. I mentioned the Institute for Healthiest Maryland with the academic partners at the schools, professional schools here in Baltimore. And then, of course, our local partners, which are health departments. I mentioned Minority Outreach Technical Assistance from the Office of Minority Health and Health Disparities, local health improvement coalitions, which work very closely with our state health improvement process. And I've mentioned repeatedly the child care providers, schools, and employers. So some of our successes, and it's a few slides remaining. So smoke-free multi-housing units, we're engaging housing authorities in these particular counties, but we're also having conversations with the Department of Housing and looking at regulations and policies to impact every multi-housing unit, low-income housing unit, and others across the state of Maryland to have specific smoke-free buildings and also smoke-free units. One of our major evaluations for the Community Transformation Grant is how many units in the state of Maryland are now going to be smoke-free as a result of this grant. We're working with other tobacco product education and educating residents in these different counties and across the rest of the counties. In Central Maryland, we now have, for example, in Hartford County, about 1,200 Hartford County employees and residents now can go to the outdoor facilities and be free from secondhand smoke is a recent change. We've also seen changes in Southern Maryland. We have a group of child care providers in a tri-county area that have been trained to provide nutrition and physical activity in partnership with the University of Maryland Extension and in St. Mary's. And then also for school wellness, we partner with these particular counties, and they have made changes in their counties to move school wellness not from a thought, but to active initiatives. Out on the eastern shore of Maryland, out by the Atlantic Ocean, we have Worksite Wellness with our Healthiest Maryland businesses, where we have a regional coordinator which works directly with those businesses in what we call the mid-shore before you get to the beach. We have training for 18 child care providers that are providing care for about 454 children in Worcester County. Healthy Stores are working in these counties to work and identify those stores, particularly that change the items that they're stocking. And then I mentioned this free, smoke-free outdoor areas, and we've had changes already in those particular counties that are mentioned. So in the state of Maryland, we wanted to briefly just share with you that even though we only had $1 per capita, but we have been able to make what we think are some significant changes, have significant conversations. So we started where we were with the relationships we had with some of the state agencies and local communities, and we expanded on what we had already. We've done what we can to reach the goals and objectives from the Community Transformation Grant, and we're not looking behind, we're looking forward. And with the relationships that we've started already, we think we're well along our way to accomplish our goals and objectives from their grant. And thank you for allowing me to participate today.
Well, no, thank you, Dr. Schell, and I really appreciate you joining us to talk about the tremendous work, the exciting work that's going on there in your state, and really, I think, just demonstrates to our audience and what incredible work you're doing across so many sectors. I mean, it's amazing to see businesses stepping up and communities stepping up as all parts of the community to affect the change in the communities that will bring around sustainable health changes, which is fantastic. So thank you. And we'll make sure that Dr. Schell's slides are available for your information to download from the Dialogue for Health website. So if you want to learn more, you can go to the Dialogue for Health website, and we encourage you to check that out, as well as the slides provided by Adrienne and also Emily as well. So with that, we're going to now open up the panelists for discussion. We have about 15 minutes left today, and now we're going to hear more about different tools and messages and resources that are available to you as individuals and community advocates to lift up the successes of the work that we've just heard about in one state, but is happening across the country, so that it can be continued, it can be protected, and it can be enhanced in the years to come. Despite the challenges we've heard about in the Capitol Hill and with the budget, it's really important that we share the importance of the Prevention Fund, and we share the importance particularly of the Community Transformation Grant Program. And so I'd like to invite now Adrienne and Emily to also join us again, as well as our other panelists today who are just joining us to help with the Q&A, which is Sana Shamini with Prevention Institute and Sue Polis with Trust for America's Health. And I wanted to actually just make it, I suppose it's a question or an observation to all the panel, which is that my understanding is obviously the sequester impacts 2013 resources. Currently, the Community Transformation Grant Program, the dollars that are being used because of the timing of when they were put on the street are 2012 dollars. And so I think, isn't it correct to say that for Community Transformation Grant and many others as well that aren't being funded out of current year, FY13, that actually if the program, if Prevention Fund and CTG is cut, it might actually be next year or the end of this year and into the next federal fiscal year that we actually see the impact of those cuts. Is anyone able to speak to that?
I can speak to it. It's a little complicated. This is Adrienne. Because of the way that CDC awarded the two different models in FY11 versus FY12, the impact on CTG will be different. The FY11 grants that were made, that Dr. Schell talked very eloquently about, are current funded. So for instance, it's a 5-year grant, I believe, and the funding for each year comes via that next year's appropriation. So each of the 5 years it's FY11 money, it's FY12 money, it's FY13, 14, and 15 money. The FY12 grants did what we called forward funding. So they made fewer awards, but they put all of the money out at once and just let you draw it down differently. So the FY12 awards, actually whatever happens in FY13, it doesn't impact the FY12 awards, it does impact the FY11 awards. Does that help?
Okay. Well, we might have to talk offline, but it certainly just demonstrates the complexity and how communities, when they're going to be receiving notice of this, are going to have to respond, and obviously recognizing the way that it's going to be impacting every activity or program differently, depending, and of course, the administration could hold CTG harmless and put the impact elsewhere. I'm not saying they will, but they have that discretion.
In the Prevention Fund, the flexibility is total. So they can take the approximately $78 million cut from whatever part of the fund they choose to.
And that answers Jenny Fernandez's question, who just sent in a Q&A, which is what is the expected cut to the CTG? It's too early to say at this point, but I think you said earlier, Adrienne, or was it Emily, that we expect to see perhaps in the next few weeks the administration will be putting on the street more information about how they would implement that $78 million cut to the Prevention Fund, including what the ratio of the cut will be, if anything, and likely to be something on CTG.
That's correct. I think, so this is Emily, I think we'll know very soon both what the cuts will be and also what the leftover allocations will be for 2013 within the next couple weeks, potentially. And also, of course, then what they have in mind for fiscal year 2014, because the budget will be coming out for the coming fiscal year around the same time. It's not clear for broader in terms of sequestration instructions when we might be hearing more. They were very quick putting out sort of a generic notice shortly after the sequestration order went out. And working with my colleagues, learned almost identical kind of from each department. They just sort of changed the budget functions they were talking about. But we have not heard anything else yet. And we're hopeful that in the next couple of weeks there'll be more guidance. I think there's a lot of anxiety, a lot of frustration, particularly not only for folks who need to figure out are they going to have their doors open or not in a month or two, but for us as advocates, you know, we want to be able to talk about the impact and communicate the impact, and we simply can't do that yet, and maybe won't be able to do that for some time.
And that also underscores the importance of people lifting up the success of the work that they're doing and telling the story in a way that, and you spoke to this, Emily, that, you know, I know it's a somewhat public health-itis that we like to weigh down our messaging with data and numbers, and data is important, but we also need to be able to tell a compelling story of the impacting communities. And that's where I know Trust for America's Health and Prevention Institute, as well as PHI, and I want to bring in Sana and Sue, the organizations, as well as many others, have resources to help people tell the story and to show cases of success. And I'm wondering if Sana or Sue, perhaps you could speak to some of those resources that are available and where people can come for more information.
Yes. Hi, Matthew. This is Sana. So we have a variety of resources on Prevention Institute's excuse me, website, and we can make sure that there'll be links coming up to those at the end of the presentation. And I actually wanted to turn your statement into a question for the other panelists, and this is picking up on Pat's statement that it would be so helpful to work together to come up with the talking points we can all use on this complex budget picture. And certainly, Emily, you provided a number of talking points that I think will be really useful. But I'd love to hear from both Emily and Adrienne the kinds of stories and packaging of stories and experiences that you feel at this moment are really going to be impactful for policymakers. You know, because we talk a lot about how to tell our prevention successes and raising the importance of telling prevention successes. But given the short amount of time we have before May 10th to provide some recommendations, what would be most impactful from each of your perspectives?
Well, maybe I'll start. I'll talk broadly. I think what's different about sequestration than our typical advocacy is that we're going to rise and fall together. Either every single federal program is going to be under sequestration or none of us are. And so even in some ways, just talking about anything can be compelling. In recognizing that if I can talk about my child's favorite teacher being laid off, you know, that's not prevention, that's not public health, but the cumulative of those types of stories, how sequestration is impacting your personal life, can help the cause to undo sequestration, if that makes sense. So when I talk about sharing your stories, and actually, I believe it's on whitehouse.gov. The White House has actually set up a database where you can share your story. Yahoo.com also has one that they've compiled, which is interesting. Just telling the story of sequestration on the ground. My husband got laid off, or my neighbor got laid off, or, you know, and it has nothing to do with public health prevention, but those types of things will help move this needle and save prevention and public health from sequestration. And maybe Adrienne has thoughts or, you know, on maybe better examples specifically, like what resonates for prevention and public health. But I feel like at this point, if you talk about anything, that will help, because right now there's sort of deafening silence. So we need to just start making noise, and it can be your professional life or also your personal life.
I think that's right, and I think it's worth it just before you reach out to a congressional office to do a really quick Google search with the congressional office name, like the politician's name and spending, and just see if they've said anything. I think making it relevant. The nice thing about public health and about prevention is that there are lots of reasons to do it. And my boss, Senator Harkin, is such a fan of public health that he doesn't really care why people support it. You know, if you support it because it saves money, great, we'll take your support. If you support it because it's the right thing to do and it saves people's lives, fantastic, jump on board. I think figuring out for you who your what's the issue that your member cares about can help you tailor the message. But I agree with Emily. I think the time is now to speak. Senator Harkin tells sort of a joke about the thing about Washington is that if you're not at the table, you're on the menu. And I think that's right. I think we need to speak up on behalf of these programs. Most people don't understand what you do, and particularly, I think, while healthcare people might understand, budget people don't always. So
that's why I think we should bring up poll 4, because this audience, you know, these are the folks that are either working directly in communities on these programs, and we recognize that for that reason, many of you may not feel comfortable taking action yourself. And I know that a couple of people, including Kate Landis, has responded on the Q&A to say that she says personally she can't, at least during work time, take action. Certainly can't lobby, of course, but we'll work with friends, family, and others in the community to take action. And then, of course, at the same time, she herself as a private citizen can take action to showcase the importance of this work. So poll 4 is really important because in the coming weeks and months, we want to be able to identify champions across the country who are willing to share their successes and their stories. And so we'd like you to reply to this poll. It's on your screen, so please on the right-hand side, respond and please let us know whether you are willing to take action. So the responses are you willing to highlight and share the successes of Prevention and Public Health Fund and the CTG program from your community? Click yes, sign me up. B is maybe, but I need some help, please tell me more. No, sorry, I'm not able to, or D, other. Now, even if you're not able to lobby, this isn't a lobbying advocacy question specifically. This could just be, are you doing a great program, you're proud of it, you just love what you're doing, and you want to be able to make sure others know about it, then please click A or B, and we can get in touch with you. This is not strictly anonymous. We can actually identify those who click A and B, and we'll be able to follow up with you and say, listen, how can we do that in your community or in your state? How can we help you to showcase and highlight your success? So please click on the reply and click response. You have a couple of seconds to do that left. Thank you. That's great. So we've got a couple of minutes left, and I don't want to run out of time before I acknowledge our speakers, but I do want to give a final last word for everybody, just in closing, to think, just to give your recommendation. If there's one, first of all, to Adrienne, what are we going to see happen in the next coming days? I've heard that there's going to be this flurry of amendments. You even addressed it, one of the questions to someone on the participant. You said, you know, what are we going to see in terms of amendments? You're going to see a lot of activity, and some of these are going to be political grandstanding. So what is your advice to people as they look at what's happening on Capitol Hill in a few days? And then I'll come to Emily and others. Adrienne first. What are we going to see?
Well, as we turn to the budget, you will see a lot of technical words like it's a deficit neutral reserve fund. A deficit neutral, anything that's deficit neutral means you probably aren't spending anything. So those things I would be a little nervous about. Sometimes they're just symbolic. Also, there are two tricks that people use to increase spending without actually increase spending in a symbolic way. They say the money is coming from quote-unquote administrative accounts. That's the people working at CDC. You know, that's the people working at NIH. It's not magic money. Or they call it Function 920, which is the administrative account. Those are generally, I mean, look, if we could have cut the light bill at CDC, we cut $100 million out of the administrative account last year. Where we can cut back on administration in the federal government, we are doing it. I think those are big signs that something's symbolic and it's not real.
And Emily, as someone leading a national coalition and representing diverse health perspectives, how can we ensure that we're not pitting one health priority against another public health priority and have a consistent message? So how can we stay together as one community? What's your advice and recommendations for the audience? You might be muted.
Oh, I'm sorry. That's a tough one. Well, I think the first thing we do is we've got to, as I say, stabilize the patient. We have to stop the hemorrhaging of cuts. And the only way we're going to do that, and let's remember how we got into this situation. There's a very vocal, I believe, minority of Americans. There's probably, a bell curve. There's a lot of people that care really deeply about the government. There's a lot of people that really hate the government, and there's a whole bunch of people in the middle who are pretty apathetic. But we have a very vocal minority right now that is completely driving this conversation, and we are mute. And I would address the comment, I can't do this. The Supreme Court has actually ruled on this, whereas you do not, because you're a public employee, or because you work for a foundation, or because you receive federal grants, forego your First Amendment rights to petition your government. You are still a citizen of the United States of America, and you have a guaranteed constitutional right to tell your members of Congress what you think. And until we start speaking up and saying this is unacceptable, we are toast. And it will become Lord of the Flies, and we will see, because I think, I do not envy Adrienne. It's a lot easier to tell Adrienne what I want than to try to do her job. So, but it's gonna come down to now these questions of priorities. And it's not a matter of, we don't think public health is important, but there are more important things that we need to be funding, like NIH research, or like national security. And we're seeing this right now, literally on the floor in the science community, that political science is nice to have, but it's not a must-have. We need to take the money we're spending in the social sciences and fund medical research. So it's starting already, and it will only get worse, and I think we'll see that in the public health space as well, that, you know what, community engagement and prevention initiatives, those are nice to have, but that's not core public health. And so in this time of austerity and limited resources, we need to invest in what's core. We don't want to, but these are the tough choices we're making. So until we stabilize the patient and stop the hemorrhaging, ultimately, and I fear inevitably, we're going to end up there. And that's a dire prediction, but if we remain timid, we remain afraid to speak our voice and exercise our First Amendment rights, that's where we'll end up, is what I'm afraid. And that's the only thing, is our voice saying enough is enough. The government does some pretty good things, that we're going to turn this ship around.
Thanks, Emily. And final remarks to Dr. Schell, if there's anything you're working in this community, you're looking at the rest of the state. Obviously, you have you're funded by these dollars, and so, but you also have an opportunity to showcase the success. Is there any closing remarks you want to make about what people who are funded by these programs, and obviously have limits by what they can do on their funded time, but can also showcase the important impact that they are making and the successes they're having? Final words from you, Dr. Schell.
Yeah, I think it's partnership, it's collaboration, it's finding out what other synergistic activities where you can take advantage of what you're funded to do and even what you're not funded to do to make a difference to improve the health of individuals in education, social, environment, recreation, and school, in all those different areas. There's a chance to improve their health. There's staff embedded in those agencies and other community-based organizations that are willing to partner with you to make a difference.
Well, thank you to Dr. Schell, and thank you to all of our panelists today. I really have valued and appreciated this incredible conversation. It's really, I have learned so much. I always do from our panelists, and it's a real pleasure to listen to you. And just a reminder that all the audio and the slides and information will be available to download following this web forum in the coming days that we posted online. So thanks to Adrienne Hallett, Emily Lubowicz, Donald Schell, Sue Polis, and Sana Shamini. And just again, thank you to all the panelists who've done a great job. And thanks to our sponsors, the American Public Health Association, Prevention Institute, Public Health Institute, and Trust for America's Health. My name is Matthew Marsom, and I was pleased to moderate on behalf of PHI today, and just we couldn't do it without our co-sponsoring organizations. And of course, thanks to the Dialogue for Health staff, Star Tiffany and Lotta Chan, have done an incredible job pulling this all together, along with our colleagues at PI and Trust for America's Health, so thank you. So that's it. Thank you very much. We'll see you next time, so watch this space, and please, please, please don't forget to take action in the coming days to fight for the Prevention Fund and Community Transformation Grant. The work that's happening is just so important, and as Emily said, we need to stop the cuts, we need to stop the hemorrhaging. Thank you so much. Good afternoon.